Hello everyone, I'm Deborah Garlick from Henpicked Menopause in the Workplace and author of the book Menopause, The Change for the Better. Thank you for joining us today, and in this session we're going to be talking about surgical menopause, and I'm delighted to be joined by Dr. Heather Currie, MBE, who is the Associate Specialist Gynaecologist at Dumfries and Galloway. I am reading this because it's such a long list of all of the credentials against Dr. Currie's name. Trustee and past chair of the British Menopause Society, co-editor of Post-Reproductive Health and the Journal of the British Menopause Society. She's also the founder and MD of Menopause Matters. If you've not been on that website yet or started to order those magazines, I seriously recommend you do. So welcome, Heather, and thank you for joining us today.
Very welcome. Thank you for the invitation.
So today's session is about surgical menopause. So what exactly is surgical menopause?
So there are different ways of looking at this. If we backtrack a little bit and think what natural menopause is, the actual word menopause is the final period. It's derived from Greek menos pausos. Menos is menstruation or periods, and pausos is pausing or stopping. So we use the term menopause quite loosely because we often use it to think about all that happens around the time of periods changing and periods stopping. But the actual menopause is the final period. But the important thing to know is that what that means is it means that the ovaries have actually stopped working. So the reason that periods stop naturally is because the ovaries run out of egg cells. They can no longer produce the important hormones during the normal cycle, particularly estrogen, and therefore we become low in estrogen. The lining of the womb isn't stimulated and isn't shed in a monthly pattern, and hence periods stop. Now, if someone has a hysterectomy, if they have their womb removed, their periods will stop, but actually that isn't the same as menopause. So although menopause means final period, we know that what we're really talking about is becoming low in estrogen. So someone who has their period stopped for having a hysterectomy, or for example, we use hormone releasing coils and that stops periods, but those types of stopping periods isn't related to low estrogen. If the womb is removed and the ovaries are still there, the ovaries will continue producing estrogen. And so we're not becoming low in estrogen at that point. And therefore, we actually won't know at which point the ovaries stop working. What we have to go by is symptoms. However, if we have the ovaries removed, which may be on their own removed or maybe along with a hysterectomy, then actually that is true surgical menopause because we have surgically removed the ovaries, and that's the same as the ovaries running out of egg cells and stopping producing estrogen. So I'm sorry that's quite a long explanation, but it is, it's the use of the terms that is quite complicated. So natural menopause, we run out of eggs, we become low in estrogen, periods stop. Surgical menopause, the true meaning is we remove the ovaries plus or minus the womb, and whichever that is, we therefore have also become low in estrogen, but because of an operation, and so that's surgical menopause.
And that's surgical menopause. And is there a difference between when you have your ovaries removed, that's an oophorectomy, isn't it? Or we're all familiar, or many of us are familiar with the term hysterectomy. Is there a difference between the two?
There is. So hysterectomy is just removing the uterus. So if that's the only part of the operation and we're in our premenopausal years, then the ovaries will continue producing hormones. So for example, we might feel like we have PMS. So those symptoms before a period, sometimes breast tenderness, bloating, mood changes, is related to the changing levels of hormones, which naturally happens before a period, and often can come as a bit of surprise. If someone's had a hysterectomy, they think that's it, no more periods ever again. And then a month later, they start to feel like they are going to have a period, but of course there's nothing there to bleed. So the hysterectomy word itself means removal of the uterus. Oophorectomy means removal of the ovaries. They can be done together or they can be done separately. If someone just has the hysterectomy and still has the ovaries and they're still functioning, they tend to work less well and perhaps stop working at an earlier age by a few years than someone who hadn't had the womb removed. And the reason for that is thought to be there can be interference in the blood supply to the ovaries at the time of the surgery.
So when you have your ovaries removed, that's it. It's surgical menopause.
A sudden dropping in estrogen, and that is the menopause, because you won't have periods if there's no ovaries there to produce the hormones to stimulate the lining of the womb. So even with the womb still in place, with the ovaries removed, that's a sudden surgical menopause.
Thank you. And I often get confused because, say, for a hysterectomy, you have your womb removed, so you're not having periods again. And sometimes people will say, well, I don't know if I'm in the menopause because I still have my ovaries, but I don't have my womb.
Exactly. And that can be difficult then to know, well, how will I know? And so what we recommend is to go by symptoms. So if a few years later you start having the flushes, the sweats, the changes that we associate with menopause, then that would be an indication that the ovaries are not working so well. And that would be the time to consider, do I need treatment for this, and what are my treatment options?
And what are your treatment options? Because this can happen at any age, can't it? It's not, when you say natural menopause, it's usually between 45, 55, on average 51, but a surgical menopause can be at any age.
It can. Fortunately, we do far less surgery, such as removing ovaries or hysterectomy, particularly hysterectomies, we do far less than we used to in the past. Many women had hysterectomies in the past because of troublesome heavy periods. We have way more options now that we can offer women, such as a hormone releasing coil, such as hormonal tablets, other things that we can offer to control the heavy bleeding without resorting to a hysterectomy. So it's now seen as a sort of last resort. And therefore, while in the past, many young women often had a hysterectomy, that's much less likely now. So the treatment options, if the ovaries have been removed, or if the ovaries stop working at a younger age than normal, or stop when they stop working and we have symptoms following a hysterectomy, then the options are the same as regards the options for someone who has a natural menopause. But you're right, it can just happen earlier. So we do know it does lead to an influence over what type of HRT if someone does choose to take HRT. So if the ovaries have been removed and the womb is still there, the HRT types are the same as in someone who went through a natural menopause. So just to recap, the main part of HRT is replacing the estrogen, because it's believed that the low levels of estrogen are the cause of the menopausal symptoms and later health consequences. So the whole point of HRT is to give the estrogen back. If the womb is still present, so if someone's had the ovaries removed but the womb's still present, we still need to add in that other hormone, progesterone, just to prevent estrogen stimulating the lining of the womb. However, if the surgical menopause includes removal of the womb, hysterectomy, then it's much simpler. And in most situations, there's a few particulars, particularly on less common situations when we have to consider progesterone as well. But generally, when the womb has been removed, the HRT can be just in the form of estrogen, which is the main part. And you don't need that other hormone, progesterone, to protect the womb lining because it's not there anymore. But the other point of when women who have a surgical menopause, it can affect sometimes the doses of estrogen required. So with natural menopause, it's a gradual reduction in estrogen. And we would normally start with a low dose of estrogen, and that might be all that's needed to control symptoms. However, if a younger woman who's had a sudden drop in estrogen because she's had her ovaries removed, we would tend to start with a more medium dose with an expectation that we may need to increase the dose gradually, because it's not been a gradual reduction in her own estrogen production, it's been that sudden drop. And, you know, we do see women sometimes who, even when they're still in hospital, before they go home, they're starting to have flushes because of that removal of ovaries and that sudden drop in estrogen. So that type of menopause can influence the type of HRT and the dosage.
And it's interesting that you should say that, because very often we hear from women who, and you know, you can understand this, for whatever reason they've needed the surgery, they're really focused on feeling better, feeling more like themselves afterwards. And for many of them, they think, that's it, I'm going to be back to myself. And then they may have a hysterectomy and the ovaries removed, and find that it's a bit like a cliff edge. They had no idea they were going to experience menopause symptoms so quickly.
Yeah, and actually what we're really keen is that women get information before surgery. So have a clear understanding about what to expect, what they might experience, what their options are. And that message should then be continued following surgery. And so that they know they're much better prepared for the after effects of surgery.
Absolutely. And you know, even us knowing that this is something that we need to consider. So if you're faced with a situation where you may be looking at surgery, then do your research yourself around what you can do to be at your best afterwards, or what your options are, rather than just focusing on the surgery in that. But also, you know, we said earlier that this can affect anybody at any age. And I know that for those that experience it at a very young age, there is actually extra recommendations in terms of treatment, aren't there?
There are. So if someone has an early menopause, so that's whether it's natural or surgical, actually, if it's before the age of 45, that's early, or if it's premature, that's under the age of 40, then the current recommendations are that the women should be offered hormonal therapy and advised to take it at least until the average age of the menopause, unless there's an absolute medical reason not to, such as a hormone-dependent cancer. And the reason for that recommendation, which applies whether or not she's having menopausal symptoms, is because as well as menopausal symptoms being the first thing that we notice when our bodies become low in estrogen by whatever reason, we know also there are later health consequences for women who lose their estrogen production at a younger age than normal. And that's particularly related to increased risk of osteoporosis, the bone thinging, with an increased risk of fracture, and also increased risk of cardiovascular disease. And so it's believed that taking HRT, hormonal therapy of whatever is the most appropriate type, at least until the average age of menopause, reduces those risks of the later health consequences.
You're right, actually, because many of us just, and particularly if you're in the thick of it with symptoms and really struggling, but it is actually just as much about long-term health, particularly because many of us are, well, fingers crossed, the average age of how long we can expect to live is increasing, isn't it? And keeping your bones and your heart and everything healthy over a longer period of time does need extra focus.
Yeah,
that needs to be. It needs to be included. And well, I'm just going to introduce my colleague Sally, who looks after questions in the background of the webinar. Hi Sally, thank you for joining us. Can you tell us, are there any questions or themes that we haven't covered already?
Yeah, absolutely. Well, I think there's definitely a key theme of people feeling that they have been through something like a hysterectomy or oophorectomy and had no information or support or understanding around menopause. And I think this is really common. And so I think people are very appreciative of today's session, just in terms of understanding and knowing what to expect. I think that can really help to empower people. We've got somebody asking, they're due to have a hysterectomy and ovaries removed in May. And they've asked, the consultant said they give estrogen gel. Should they start it straight after surgery? Is that normally the recommendation in terms of when would somebody start, or would it just be once someone starts struggling with symptoms?
Yeah, so it depends on the type of HRT. So with estrogen, there are two main routes to take it. One is through the mouth, so swallowing a tablet a day, and the other is through the skin. So the skin is known as transdermal, and that might be a patch or a gel or a spray. So around the time of surgery, there is for everyone a slight increased risk of having a deep vein thrombosis. We know that with tablet estrogen, there is a slight increased risk of deep vein thrombosis. So in a practical way, if the choice is for someone to take a tablet, then actually it probably is worth waiting a couple of weeks or so, because you don't want to add to that around surgery time of blood clotting risk. However, if the choice is to use transdermal, so a patch or a gel, then that's just replacing estrogen in the way your body is producing it until the point of surgery. So it could be started pretty much straight away. And there are lots of types and lots of dosages, and there isn't one that suits everyone. So I noticed that said recommended a gel, but I would be keen to know, is that what she wants to take? Has there been a discussion about the different options? Because people don't all suit the same thing.
Yeah, Absolutely. And we've got a few people saying that they've had hysterectomies following challenges with endometriosis, and so HRT hasn't been recommended, and they're just worried about their cardiovascular health, their bone health. Any kind of recommendations or things that people should be thinking about to look after that long-term health where HRT may not be a possibility?
Yeah, so endometriosis is one of those situations when it might be appropriate not to give just estrogen. So as I talked about, normally if the womb has been removed, then taking the main part of HRT, which is estrogen on its own, is the way to go. However, with endometriosis, if it's been quite extensive, and endometriosis is where you get little bits of the lining of the womb, the endometrium, sort of deposited outside the womb. So sometimes on the outside of the womb or on the ovaries. And in the normal monthly cycle, these little areas are stimulated and can cause some inflammation and pain. But you can also get endometriosis on the bowel or the bladder, on inside the wall of the pelvis. And so if a hysterectomy is been carried out for that reason, and usually the ovaries would be removed at the same time, there is the potential that maybe little deposits in other areas. And if you give estrogen only following that type of hysterectomy, there is a possibility that these areas could be stimulated. So it's theoretical. We don't have a lot of research about it, but the general recommendation is if there has been widespread endometriosis followed at the time of a hysterectomy, then HRT can be considered, but it would be in the form of estrogen and progesterone, giving both hormones every day. And the theory of that, it should be less likely that any deposits would be stimulated.
Okay. And for somebody who's not recommended taking HRT because of the particular cancer that's being treated, again, from a long-term health point of view, especially if this has happened early in their lives, any things that they should be thinking about in terms of things like bone health, cardiovascular health, if HRT isn't a possibility?
So there's a lot of diet and lifestyle advice that can be helpful for bone health and heart health. So the biggest one is not smoking. Smoking is bad for our heart and bad for our bones. So, really, it's so easy for me to say don't smoke. I realize how difficult it can be, but this is just another reason, to try. And what I say to people, never give up on the idea of stopping. Appreciate how difficult it is, but just always, keep that one day I'm going to do that. Not being overweight, not drinking too much alcohol, caffeine, plenty of exercise. There's no specific advice. It's the normal advice that is really good for our heart and our bones. And then, there are other techniques. So sometimes for the sort of mood changes, then cognitive behavioral therapy can be really helpful. And there are some alternatives that some people find helpful. Yoga can be helpful. There's a whole load of things that we can offer. And it's just, it's really important that women have access to information so they can find what's going to best suit them. For someone going to a gym regularly, for me, that would be a nightmare. I just know I wouldn't do it. But actually getting out walking is fantastic, and it has so many benefits. So it doesn't need to be expensive type exercise. It's just something that we can all do, and something that you enjoy, and therefore you're more likely to keep doing it.
Absolutely. I know we talk in our sessions about getting outside and finding things that give you joy and moving more and being more active rather than necessarily needing to be specific exercise. And I think that definitely makes a big difference for people. Someone just sorry,
it's very good for us as well, isn't it?
Yeah.
So nutrition, we always recommend that people look at the diet in particular. And I know I'm known for my cheesy Wotsits and chocolate ice cream, but I do always make sure I get a balanced diet on top of it, because you can't underestimate the importance of things like calcium in your diet, and making sure you're getting a lot of variety in that sort of way as well, combined with the lifestyle. I do love my gym, actually. So, at least I tick one box.
Absolutely. So there's a question here that someone just wanted a bit more of an explanation around how the benefits of HRT for somebody with who's been through a surgical menopause, because I think they're just feeling a little bit confused around some of the narrative around HRT is there to top up hormones during perimenopause, and because that's not what they're going through. Just a bit of a summary of what could the benefits be for somebody.
It depends really on the age that they have the surgical menopause. So if someone requires a hysterectomy plus or minus the ovaries removed and particularly those removed actually, at the time when the periods have already stopped, they'll have already become low in estrogen. And so sometimes we do find that people who'd already stopped periods in recent times, they have the surgery, and then they previously may not have had menopausal symptoms, but then they can occur. And that's probably just because the ovaries were still producing a little bit of estrogen. And when that drops further, when the ovary is removed, then that causes that drop. But for some women having surgery around the normal or into that postmenopause, then actually they may not need HRT if they're not having symptoms. And what we normally advise at that time is say, well, actually, you'd already become low in estrogen. Just see how you go after this. You don't have to start something straight away. But for the women who had normally functioning ovaries removed, then they are getting a drop in estrogen, and therefore it's likely that they will have menopausal symptoms. Not always, because it also depends on the reason for the surgery. If someone was having a terrible time with periods, with PMS, that the normal medical treatments are not helped, that can be a life changer, having that surgery. And actually they may feel really well because they've not having the problems that they were having before. But then with the younger women, especially, as we've mentioned, there's not only the idea about controlling menopausal symptoms, but it's all about those long-term health benefits as well. So what replacing estrogen does, it's the most effective treatment we have for controlling menopausal symptoms if they are present. And it's always also good for our bones, our heart, which is particularly important if an earlier menopause than average, if we lose our estrogen at a younger age for whatever reason.
Fantastic. And someone's asked around at what stage to come off HRT, especially if it's being taken post-surgery because they had that surgery at a very young age. At what stage? Are there any risks of coming off? Any recommendations around making those decisions?
That's a very good question and a very difficult one to answer. So I'm gonna waffle and be vague because there isn't a definite thing.
No.
For the younger women, the advice, as I mentioned, related to the longer term health problems is to take it at least until the average age of menopause, so the early 50s. At that stage, they're then in the same situation as someone would be if they were going into natural menopause at that time. And then, it is reasonable to come off and say, well, actually, will I be having symptoms? How will I feel? Because unless you come off it, you don't know that. But knowing that if you come off it, and anytime someone comes off it, we do recommend a trial of at least 3 months, if possible. Having said that, if someone immediately gets recurrence of symptoms that are really troublesome, and 2 or 2.5 months down the line, they're not showing any sign of reducing, then, it would be reasonable to say, actually, I'd rather go back onto my HRT. So, but you do, staying off it just a week isn't going to give you a fair assessment. So sometimes symptoms do come back, but then they settle in time. And the other thing to take in mind is actually, it's not just about your symptoms, it's what is the impact of the symptoms. So, we've talked about a lot before, the timing of menopause is awful. Surgical menopause might be at a different time, but for all women becoming menopausal, they could have lots of stresses going on in their life, and the symptoms can have a different impact depending on what stage you're at, depending on how many stresses you have, if you have teenage children, if you have elderly parents, you're worried about what's going on in your career at that time. There's a whole load of stress goes on. And so many women will feel, actually, when I'm a different stage in my life, if I have symptoms, then I'll be in a different position to deal with them, so it's life is changing. It's not just our hormone levels that are changing, and all that needs to be taken into account. And I think often women, they make the decision themselves, actually, I'll have a go of this now. I wouldn't recommend doing what I did, which I tried to come off it during being in a very senior position at our hospital during the pandemic. I mean, that was never a good idea. Why I ever thought that was a good idea, I have no idea. But then I did try again, last year, and it's worked. It's fine. I'm absolutely fine without it. So it's just the individual thing, isn't it, around finding what's right for you.
Fantastic. Thank you. Oh, you're on mute, Deborah.
Thank you. That'll be edited out. But one of the things that you did mention was about the variety of HRT products, and there are some new ones on, aren't there? And I know we do a happy dance whenever we see some new ones coming out with lots of research about their effectiveness. And is it Theramex is the latest one? Was that by Jove? Which is a new tablet, isn't it?
It is. So actually, 25 to 30 years ago, when there was lots of confidence in using HRT, before we had that sudden drop in confidence and drop in prescriptions, then there were new products coming out all the time. And it's great to have so many options. We used to have a nasal spray. We used to have a vaginal ring that released estrogen throughout the body. And then they were, certain products were gradually coming off the market because, as we've said before, there isn't one type that suits everyone. So the more options you have, the better. So fairly recent has been developed a spray, an estrogen spray that goes through the skin the same way as a patch or gel. And we have some new vaginal estrogen products that have come out recently as well. And the recent one that you mentioned is a tablet, a daily tablet that contains estrogen and a certain type of progesterone. So it's just great to have more options, really, because often the effect of estrogen varies. So having different ways of giving estrogen is great, but also that progesterone bit that's needed for the lining of the womb, that protection, that's often the one that causes side effects. And when you have different types of progesterone, you can usually tweak it to find which one suits each woman.
Fabulous. Thank you very much, Sally, for fielding the questions, and Dr. Heather Currie for joining us today. And don't forget to sign up for Menopause Matters. How do we do that? Do we go through your website? Is that the best way to subscribe?
Yeah, menopausematters.co.uk.
Or just ask Alexa if you want some information, because that takes you directly through Menopause Matters. Is that correct?
It gives information that's from Menopause Matters, yeah.
That's wonderful. So, so you could have it in your Alexa voice as well. Thank you very much for joining us today, and look forward to speaking again soon. All the best.